Hi there, I will be talking in this video about the basics of infectious disease epidemiology. So we'll cover the epidemiologic triangle briefly and talk about how we use it to understand and control infectious disease, talk about some definitions, so endemic, epidemic, and pandemic, briefly describe some data sources that are useful in infectious diseases, and then talk about epidemic curves and how we use them, interpret them, and finally talk a bit about disease eradication and specifically about herd immunity and why it's an important concept. So first, you're probably familiar with this sort of figure, which is showing the epidemiologic transition. Essentially, over the course of the 20th century, we shifted from a situation where infectious diseases were among the leading causes of death to a situation where they still cause a substantial number of deaths each year in the US. But by far, the predominant concerns are now chronic conditions and diseases. Nonetheless, infectious diseases and agents continue to be important, as is currently illustrated by the COVID-19 pandemic. And so it's still important to know about infectious diseases and some of the unique aspects that we think about in the epidemiology of them. The first is this epidemiologic triangle, which also is probably familiar to you. And really, it's just emphasizing the fact that infectious diseases in particular have to do with this multifaceted relationship between the host or the person who is sick, the agent or the pathogen that's causing the disease, and the environment. And so often, this triangle can suggest both the causes of disease. So if we want to think about how people are getting sick, it could be that we can sort of understand or develop theories about the agent or the pathogen based on what we observe about how the disease is moving through populations based on host characteristics. We can also think about what interventions there might be to prevent disease by using this triangle. So as the slide shows, you can intervene at any of these points or any of the sides of the triangle, whether it's breaking the host agent interactions, making interventions in the host environment relationship, or even the environment and pathogen relationship. So the textbook chapter goes into a lot more detail about this, and I'm assuming you're somewhat familiar with it. So just a reminder here. Also, these terms may be familiar to you, but I want to make sure we're all on the same page. And so when I'm talking about an endemic disease, that means one that's occurring at sort of an expected rate within the population. So this will, of course, vary depending on what the population is. You know, if we see cases of something like malaria here in North Carolina, that would be unexpected, but there are certainly regions of the world where there are cases of malaria routinely, and so they happen at endemic levels. So these are not specific to a disease, but instead specific to a population. So once the number of cases or the rate of infection goes beyond the endemic level, it reaches an epidemic or outbreak situation. So that's more cases than we would anticipate. And so again, this varies depending on where you are, what population you're looking at. And a pandemic, which again, we have an example right now with COVID-19, is when there's an epidemic level of disease across populations globally. So just like in other aspects of public health and for other types of disease, we have surveillance systems that are available to help us identify epidemics. Within the US, we have a national notifiable disease surveillance system. I'll talk a bit more about that on the next slide, but the link is here. We also have a foodborne disease specific surveillance system called FoodNet for short. And there are some data accessible for that online. During flu season, which we're coming into, we have influenza-like surveillance networks where providers participate and labs report to that. And then there's a flu view, which is this weekly US surveillance report on influenza during the season. So the National Notifiable Disease Surveillance System, as it says here on this slide, there's more than 120 diseases that are covered by this system. So these are mandatory reporting diseases. If you're a healthcare provider or a lab or work at a county health department and see a case, you must report it up to the state level, and those get aggregated to the CDC. And this covers a lot of infectious agents, also some things that might be associated with bioterrorism, And there are a handful of non-infectious conditions on there as well. But this tends to be things that are important public health issues, might be sentinels of really serious problems, that sort of thing. This slide illustrates the epidemic threshold, which appeared on an earlier slide, but I didn't mention yet. And this just demonstrates that, again, we expect some level of disease to occur in the population. So this particular slide is from an MMWR that was showing influenza, well, pneumonia and influenza is actually what it's tracking, but you know, this is reflective of the influenza burden for the year. And so the two black lines show the lower bound of the seasonal baseline, like what we'd expect to see, sort of the endemic level of that lower black line. And then the upper black line is the point at which we'd consider it an epidemic year. And so as you can see from this slide, most of the years between 2010 and 2015, we had epidemic levels of pneumonia and influenza. So one way we can understand epidemics, outbreaks, is to plot a curve. And so an epidemic curve is what we call it when we're focusing on an infectious disease. And essentially it's just a plot of the number of cases of disease that shows up on the y-axis, and then time is across the x-axis. And so it can help us understand both the quantity of disease, the rate at which things are happening, and what type of spread there might be. Again, if we don't know the infectious agent, this can be particularly helpful. So there is more nuance than this, but the two broad categories of types of outbreaks or epidemic curves are a point source and a propagated epidemic. So point source means that everyone had the same exposure at the same time. So this is typically what you would think about if it's a foodborne outbreak or waterborne. You know, if there's some specific contaminant or infectious agent that everybody in a community is exposed to through the water, or everybody who attends a picnic eats the same thing. And so we see this very sharp rise in cases. There's just one peak in the curve typically, whereas with a propagated epidemic, people are exposed at different time points, and it might be a protracted period of time over which that happens. And so typically it has a less steep curve, and there could be multiple peaks, or it could be kind of a protracted, not even really a peak, just kind of a large flat portion of the curve. So the next two slides show you some examples. So this is what it might look like if you had a point source outbreak. Even in this one, there are two peaks because there is some spread that happens. So often they don't look perfectly beautiful when you are doing an outbreak investigation. But you can see here we have an index case, so that means the first person to get sick. And then that person spreads it to another group of people. And so we see that first case in the curve show up in the minimum incubation period for that agent. And the incubation period is the time between when someone is exposed to an infectious agent and when they start to show symptoms or actually be sick. So in a point source outbreak, we expect the peak of the curve, the peak of the epidemic curve, to be right around the average incubation period, because you would expect that most people who got exposed to this person would develop symptoms around the average incubation period. And then we expect the curve to, start to really decline by the maximum incubation period. And so we see here there's actually a second curve, or second peak, at the maximum incubation period. And so that's where it suggests that it was not a single point source, that somebody else was spreading it to other people. But then the curve does go back to being flat. And so that's why we say it's limited spread, maybe 2 point sources really in this scenario. Contrast that with this graph, which shows a more disseminated outbreak. So this would be propagated spread. And so there is an initial peak. There's the index case, and then there's an initial small curve that peaks around the average incubation period. But you can see that then it keeps going. So this suggests that those people from that first small peak are then infecting other people, and they're infecting others, and so on. And so we see this increasingly growing spread of cases. So to correlate that with the COVID-19 outbreak, this figure is kind of one nice looking sort of single peak These data are just from China, so this is from the early outbreak in Wuhan. And you can see even here, even though it looks like it could be a point source because it is a nice, almost normal curve over there to the right, we see this little inset part that shows us that it looks propagated from the beginning. There's a single case, and then there's a small peak, and then it keeps getting bigger and bigger. And so this is a propagated spread over time. Similarly, I just wanted to show you, so that's essentially this curve here from this is from a research article. This curve is essentially what we can see on this next slide in the orange down here. These are cases through March of 2020, and the orange represents the Western Pacific region. So it's not just China, but China was the primary place where there were cases in January, February of 2020. So that's kind of the low curve on the bottom, but you see really incredibly rapid rise and spread as people became sick outside of the Western Pacific region over the course of the spring of 2020. And then this is a more recent figure showing the cases and deaths globally through November. And so again, that the previous slide only went up to March. So while it looked like maybe this was the peak of a curve, in fact, it was not. There was a high point in terms of deaths, certainly in March, but we see this protracted spread and continual increase over time. So the next question, of course, is, and what we're talking about with COVID right now, is how do we get rid of these infectious diseases? Because when they are spread from person to person, or when there are reservoirs in the environment, it gives us the opportunity to eliminate them. So there's a few different ways we can do that. The first is through vaccines. And so that's certainly something that's being worked on now with COVID. And I just want to show you a couple of historical examples of vaccine preventable diseases and the dramatic impacts they can have. So this is measles cases in the US from 1950 to 1997 is the main figure here. And you can see there were hundreds of thousands, 600,000 to 700,000 cases of measles every year in the 1950s. And then once the vaccine was licensed, we see a pretty precipitous drop. And within a decade, we're down, to just a few thousand cases of measles every year. And it reaches near zero in the 1980s. But as often is the case, when we have public health success like this, sometimes we start to let our guard down, immunization rates drop, people's concern about negative effects of vaccination, which are unfounded scientifically, outweigh their perceived benefits of getting children vaccinated. So we start to see vaccination coverage drop, and that leads to resurgence of these infectious diseases. And so the inset figure at the top here shows data from 2010 to 2019. And while we're clearly nowhere near the 1950s levels of measles cases, there were almost 1,300 cases of measles in 2019, which is a substantial increase over time. And of course, looking at this, you can see there's a lot of variation year to year. It just depends on the size of the outbreaks. But it's concerning that, the big year in 2011 was 200 cases. Then in 2014 is another big outbreak here. There were 600 cases. And then last year, another big outbreak here, but we were up to 1,200. So data suggests both vaccine coverage rates and these kinds of trend data suggest that we're going to continue having more cases of measles each year. Similar situation with pertussis. So this is also known as whooping cough. Again, you can see large numbers of cases, a couple 100,000 cases a year, excuse me, in the 1920s up through about 1950, when the first vaccine was licensed, and then a pretty dramatic and quick drop down to, this was not near zero, even though it looks like it. There were still about 1,000 cases a year in the 70s to 90s. But then we start to see this increase again. And by 2015, we're up, 2015, there were about 20,000 cases. We had a spike as high as about 50,000 cases a few years before that. And that's held about steady. So the last few years we've had around 20,000 cases per year. So again, just decreases in vaccination coverage can explain this increase in the number of pertussis cases. So vaccines are important because they can prevent disease in individuals, but perhaps more importantly, from a public health perspective, they help us achieve herd immunity, which you probably also have heard a lot about since COVID, if you hadn't heard of it before. So herd immunity is essentially just the concept that if a lot of people in a population are not susceptible to disease, even if one of them gets it, it's unlikely to cause a dramatic spread. And so I think this figure from PBS illustrates it nicely. In the top panel, most everyone in this population is susceptible. And so if just one or two people get sick, it's very quickly going to spread throughout the population. In the middle one, there are some people who are immunized, but most people are still not immunized and at risk. And so again, it still spreads pretty quickly through that population. But the bottom situation is what we're aiming for with vaccines, which is there are always going to be some people who cannot get it for immune compromised reasons, or they have other risk factors, they're allergic to the vaccine, etc. So we want to cover as many people as we can so that when somebody in the population gets sick, they're just unlikely to interact with one of those people who is still vulnerable. So herd immunity, it certainly works as a concept. As you also have probably heard, it's not a great option as a primary way to control disease because it's going to result in overwhelming healthcare system capacity and most likely more deaths as a result, because more people will become infected and get sick rather than achieving immunity through something like vaccination, which carries much lower risks with it. So what do we need to reach to be able to achieve herd immunity? It depends on the disease. It depends on a few factors of the disease. So how long people are immune once they get sick, what the disease transmission pathway is like, how virulent the particular strain is. All those things matter. But essentially what we typically use is this R naught, or the reproduction number. And that represents the number of people who could get sick if one infected person came into a totally naive, a totally unprotected population. So to the right here, I have some examples to show you what the R naughts look like. So for measles, it's actually very high. And so that's how we do often get these large outbreaks. So if one person in a population, in a community where no one has immunity to measles were to get sick, they would be expected to infect between 12 and 18 other people. Whereas at the other end of the spectrum, mumps, the R naught for that, if someone gets mumps, it's not as easy to transmit. So we'd only expect 4 to 7 people who would get sick from one person if it were a completely non-immune population. So you've probably heard that we estimate, although we're not certain yet, that COVID is probably around 2, maybe 3 as the R naught. So not anywhere near measles, which is good news. And although there's not a direct translation, there is a correlation between the R naught and the threshold percent, meaning the percentage of people we would need to vaccinate in a population in order to prevent the spread of disease. You can sort of see just by looking at these numbers that about 80% is a good ballpark, just in general. So many of our goals relate to vaccinating between 80 and 90% of people in order to achieve herd immunity. And so expectations are, again, just based on this, looking at these numbers, we might need to get to about 70 to 80% for COVID-19 in order to achieve herd immunity. So vaccines can help us achieve eradication, as I mentioned earlier. That's how we eradicated smallpox, which is the only infectious disease we've successfully eradicated. We are close on polio. There's a link here to polioeradication.org. It is only endemic currently in 2 countries, Afghanistan and Pakistan, but there are circulating cases from the vaccine itself in a number of countries in Africa. Also, guinea worm, which is not actually a disease, it's a parasite, but it causes drunculiasis, and that requires an environmental approach to controlling the spread. And so there have been efforts made, and it's been nearly eradicated, but it has found a reservoir in other animals, namely dogs, and so it continues. So there are a lot of cases like that where we come near disease eradication, but often there's some other reservoir, some other animal that can be infected, and so it becomes very challenging to eradicate. The other reason that we have barriers to eradication are mutations. So influenza is definitely one of those examples. It has these two surface proteins, hemagglutinin and neuraminidase, that mutate very rapidly and can sometimes jump between species. And so that's why we get things like influenza pandemics every so often. But even without pandemics, every year we need a new vaccine because there's different strains circulating, and it mutates so quickly it's very unlikely we'll ever be able to eradicate it. So the 1918 H1N1 influenza pandemic is probably the most well-known. It killed about 50 million people worldwide is the best estimate, which would be more than died during World War I, which is when when it occurred, essentially at the end of World War I. And that one was unique in that it had a particularly high mortality rate among young people. And as a result, the life expectancy in the US actually declined by 12 years after that pandemic. So lots of additional resources. There are some listed here. There are more on the class website if you're interested in infectious disease epidemiology. The Morbidity and Mortality Weekly Report published by CDC tends to have the most up-to-date and emerging information about conditions. CDC also offers a number of really nice case studies and full courses. It hosts the Epidemic Intelligence Service, which is a training program for physicians, nurses, and other healthcare providers who want training in epidemiology and infectious disease. And so a lot of those resources are available on their website. And then if you want something that's a little bit more fun, they actually have a really nice Solve the Outbreak game where you go through different scenarios. So that's all for this session. Next time we'll be talking about doing outbreak investigations and trying to figure out the causes.